बीते दिन CME ऑफ फिजिशियन फॉर्म बठिंडा ਵੱਲੋਂ एक विशेष सैमीनार करवाया गया जिसका टॉपिक सी एडवांसेस इन मैनेजमेंट ऑफ डायबिटीज़ मेलिटस बाय रिनाउंड डायबिटोलॉजिस्ट एंड एंडोक्रिनोलॉजिस्ट ऑफ बठिंडा। ਇਹ ਸੈਮੀਨਾਰ ਫਿਜੀਸ਼ੀਅਨ ਫਾਰਮ ਬਠਿੰਡਾ ਦੇ ਸੈਕਟਰੀ ਡਾਕਟਰ ਬੇਅੰਤ ਸਿੰਘ ਮਾਨ ਜੀ ਦੀ ਅਗਵਾਈ ਵਿੱਚ ਕਰਵਾਇਆ ਗਿਆ। ਸਾਡੀ ਟੀਮ ਨੇ ਡਾਕਟਰ ਬੇਅੰਤ ਸਿੰਘ ਮਾਨ ਜੀ ਨਾਲ ਗੱਲਬਾਤ ਕੀਤੀ ਜਿਨ੍ਹਾਂ ਨੇ ਸਾਨੂੰ ਇਸ ਮੀਟਿੰਗ ਬਾਰੇ ਵਿਸਥਾਰ ਨਾਲ ਜਾਣਕਾਰੀ ਦਿੱਤੀ। ਆਓ ਲੈ ਕੇ ਚੱਲਦੇ ਤੁਹਾਨੂੰ CME ਆਫ ਫਿਜੀਸ਼ੀਅਨ ਫਾਰਮ ਬਠਿੰਡਾ।
Compulsory so that we can conduct these meetings in a better way and we can update our academics regularly and basically we should introduce ourselves because many of us are new in this position form and please I request all of you please introduce yourself one by one please. Doctor please. No, that's all. That's all. MD medicine. Please give them mic first.
डॉक्टर आपके प्रधान MD मेडिसिन प्रधान नर्सिंग
I am sorry, please. I forgot that Madan is the president.
I am the president of physician. Thank you. I am from Delhi Heart Institute, consultant physician. Dr. Abneet, I am a DM Public Medicine, consultant at Adesh Medical College. MD Medicine, practicing at Civil Hospital Bathinda. Pradeep Kirtal, practicing at BB Bala Road. Under the name of Rohtak Nursery.
I am the endocrinologist and working in Medicare Hospital.
Hello, I am Dr. Simranpreet Khan from Apex Hospital, Ramgarh, MD Medicine.
Myself, Dr. Anupreet Goyal. I am MD Medicine and working at Cosmic Super Specialty Hospital. Good evening everyone, I am Dr. Shilpa Gupta, MD Medicine, working as consultant Punjab Cancer Care.
I am Dr. Hemant Gopal, consultant rheumatologist at Gloucester Med Center, Model Town, Bhatinda.
I am Dr. Gaurav Jain, Sarvejri Hospital, DMD Medicine.
I am Dr. Jain Agrawal, MD Medicine, working at Bathinda Neurospine Hospital.
Myself Dr. Kavinder Bansal, ex-PCMS, now working at Prime Care Hospital.
Myself Prashant Mittal, working as consultant physician at Mittal Hospital.
I am Dr. Shokmin, MD Medicine, working as consultant physician at Civil Hospital, Bhatinda.
Myself Dr. Mishuri, ex-assessor.
I am Dr. Narendra Grover, MD Medicine, working at Civil Hospital, Patna.
Dr. Sahas Jindal, MD Medicine, working at Civil Hospital, Bhatinda. Dr. Bharatbhushan Jindal.
So, I heartily welcome all the members in our first meeting. So, Dr. Maheshwari has taken the very hard efforts to streamline the working of the physician forum. As we usually see, the physician forum was a big gathering, but we were having the attendance of only 10-20 people. So, he has tried to make our streamline. He has guided us to come whenever we arrange a meeting, come prepared and ask some question also and take the part in the physician forum discussion also. So we are happy that we will try our best to come to his expectation. So what I noticed today, in spite of the hard efforts and hard warning given by the Maheshwari, पर चेहरे सभी फिजिशियन फोरम के आज खिले हुए हैं, in spite of the hard warning. The reason you know better. So once again I welcome all the members and we start our meeting today. Thank you.
Lifestyle diseases have two phases or two reasons. One is excessive food intake, calorie dense food. Another is lack of exercise. And all the two arms I will not be able to discuss. I can briefly discuss the effects of chronic exercise, physiological effects of chronic exercise and the benefit thereof. First, physiology of exercise means study of effects of exercise on human body and response of various organs and tissue to exercise. First type of exercise is a single bout of unaccustomed exercise which leads to following alterations. First there is a rise in heart rate, rise in respiratory rate, rise in BP, rise in pulse rate, rise in respiratory rate, increased cardiac output, levels of catecholamines and cortisol they rise, and there is accumulation of lactic acid in the concerned muscles. The body metabolism temporarily tends to rise and rise of temperature is there. And there is a fatigue and lactoacidosis in the body. This is the effect of acute bout of exercise of an unaccustomed person who is not an athlete or not a regular worker. But this is bad because this can cause sudden death and so many other things, because pulse pressure is very high, ischemia is there, relatively ischemia would be more. Now effect of chronic physical activity which decreases all these things and normalizes all these things, so the danger becomes very less. The effects of chronic exercise on human body. Long-term adaptation of regular exercise results in the following. Number one, there is an increased cardiac output. There is an increased aerobic capacity and tolerance. And there is also an increased anaerobic capacity tolerance. Resting pulse rate and resting respiratory rate become less. There is lowered response to catecholamine and cortical. The secretions are lower and the response to them is lower. So the dangers are less. Development of new capillaries in the mitochondria, new capillaries and mitochondria within the skeletal muscle as well as within the cardiac muscle, it occurs. That means the oxygen supply very efficient. There is a decrease in liver fat which is being utilized. Bad lipids are lowering down, good lipids rise. There is a decrease in number of cardiovascular deaths and strokes. Loss of weight is there, decrease in BP is there, decrease in diabetic status is there, anti-inflammatory effect is there, immuno-augmentation is there, and there is bone density increase, and also their ligaments become stronger. So this makes you strong, this makes you, and even when the person loses weight, his normally respiration is mainly thoracic in obese people. This becomes abdominal thoracic. So even the volume, this volume of the respiration, I have forgotten the technical name, this becomes very high. So the anoxia and the causes thereof become very less. So physical exercise is very important in preventing all this, and this will decrease the number of patients visiting Shweta and Kotro.
This co-formulation, that is IDEC acid. So disclosure is, these slides are not mine, they are provided by Novo people. So today's agenda will be, firstly, how to initiate IDEC acid and how to intensify it. So first case, we have Mr. Abhishek. He's a 50-year-old male. By profession, he's a lecturer. So if we see the medical history, and he's been diabetic since 2010, and he is dyslipidemic. So presently, the medications that he has been on, he's on metformin 1 gram BT, dapagliflozin 10 milligram once a day, and the glimepiride 2 milligram twice a day. And simultaneously, he has been taking aspirin as well as atorvastatin. So if we see the results, the fasting blood sugars is 178, postprandial 302. That means if we see for the difference between the fasting and postprandial, it is more than 50. And the HbA1c is 10.2. That means again the blood sugars are totally uncontrolled. The creatinine is 0.8. We have to calculate the EGFR for this patient. And then the LDL, if you see for the cholesterol levels, their total cholesterol is 224 with the LDL of 102 with the triglyceride of 174. That the cholesterol levels are still under control. So what are the issues that we are going to face with this patient is that presently the patient has uncontrolled blood sugars, and then the patient's even the cholesterol levels are on higher side. So what we can manage this patient? How do we manage such kind of patients? So either the options that are available to us, either we can increase the dose of OHs that are available to us, or we can initiate the insulin. So how about increase the dose of glimepiride? So already the patient is on 2 milligram twice a day. He is on 4 milligram. So if already the patient is on 4 milligrams, that the 50% of the dose, that is the total maximum dose of the OHs that we provide to a patient is of glimepiride is 8 milligram. And if the patient's blood sugars is not being controlled with the 4 milligram, that is the 50% of the high dose, that means the patient will not respond if still we are going to increase the dose of glimepiride either by 6 or 8 milligram. There is no point of increasing the dose of glimepiride. So it's better to keep, do not increase the dose of glimepiride, because we are going to increase the risk of hyperglycemia rather than hypoglycemia rather than achieving the glucose control. So what about start the insulin? So yes, definitely, because his blood sugars, the fasting is also higher side, postprandial is on higher side, and the difference between the fasting and postprandial is more than 50. That means the patient will be requiring either the basal bolus regime, premix insulin, or any co-formulation that will control both the fasting and postprandial. It is not going to get controlled with only the basal insulin. So then another option is either we use alternate SGLT2 inhibitors. So the alternate to the dapagliflozin that are available to us is either we can use the empagliflozin, or either we can use ganagliflozin or remogliflozin. But still, if we see for overall HbA1c, that is the patient's HbA1c is 10 and we have to get it to 7. So even if we are going to change the SGLT2 inhibitors, we are hardly going to achieve the HbA1c control. Then, or we can add DTP4 inhibitors. Definitely we can add DTP4 inhibitors. The better what will be if we can increase the SGLT2 inhibitor with the better efficacy than dapagliflozin and simultaneously add DTP4 inhibitors, that can simultaneously decrease the HbA1c by 2 points. Or either we add GLP-1 agonist. Definitely again it is a better option if the patient is affordable. GLP-1 agonist can significantly decrease the A1C levels. So now what does the guidelines recommend? So this is the RSSDI guidelines. They say if the patient is already on multiple OADs and still we are not able to achieve the glycemic target, better start with the insulin. Either we can start with the basal insulin, premix insulin, co-formulation, any insulin. If the patient is already on 3 or more OADs, that means the patient is having secondary OHA failures. Better start with the insulin rather than it. So in this, the IDEC is again, they have said that it is preferred choice at insulin initiation. So RSDI, this is the 2022 guidelines. So they do recommend either we can use a premix, that is 30/70 or 50/50, or biasp or co-formulation, that is the IDEC aspect, can also be started. So all these drugs, all these insulins, they have efficacious, and most of the patients can be initiated either with a co-formulation or premix insulin, as depending upon the patient scenario. So the patients who have uncontrolled blood sugars, these premix, even the patient who has higher postprandial blood sugars, they can benefit with the 50/50 insulin. So because these patients, they will be benefiting those who have higher postprandial glycemic excursion. So how do we start the insulin? Definitely again it is by the 10 units OAD or 6 units BD, which is followed by, then we have to titrate according to their blood sugars levels. So again the RSSDI, they also recommend that IDAC-ASP can be the choice for insulinization because it causes the least hypoglycemia and definitely the requires fewer doses and it causes less weight gain. So this was a study which was again defined the efficacy and safety of IDAC-ASP. Again, it showed that it has better glycemic control as compared to Glargine U100 and with a low risk of hypoglycemia. So definitely IDAC-ASP has superior HbA1c reduction and better fasting blood sugars controlled with a low risk of hypoglycemia, and it does control the postprandial glucose levels also. If we check for HbA1c levels and for the fasting postprandial blood glucose excursions as compared to the Glargine U100 or 300, again the IDAC-ASP has better reduction in both the scenarios of HbA1c fasting as well as PB. So if we compare now requirement of insulin dose, whether if the patient is on IDAC-ASP, Glargine U100 or 300, again it was seen that the patients who were on IDAC-ASP, the number of insulin dose requirement was again less and the patient was having lesser risk of hypoglycemia. So this is the time to treatment intensifications. What they saw was the patients when they were started on IDAC-ASP as compared to when the patients were started on Glargine U100. So this is called the time to treatment intensification. That is time between the index state, that means at which the patient HbA1c was more than 7% on the existing therapy, and the first prescription for additional anti-hypoglycemic agent or insulin and during the follow-up period. So this was, again it was seen that the patients who were on IDAC-ASP, they were better, 11.6% of these patients, they were better intensified treated as compared to the patients who were on Glargine U100. So now coming on to, if we want to switch the patient from IDAC-ASP, from the Glargine U100 or 300 to IDAC-ASP. So again, so if we can clearly see, we have to see for the, what is the insulin dose requirement, whether the patient's quality of life was better or what was the treatment preference. So if we see for this scenario, the insulin dose requirement in the patients who were having on IDAC-ASP was lesser as compared to the patients who were on Glargine U100 or 300, and the quality of life was better with the patient on IDAC-ASP, and the treatment preference definitely was because it was once daily dosing or twice daily dosing, patients preferred IDAC-ASP. So switching to IDAC-ASP was associated with low total and basal insulin dose requirement, and there was a better improvement in quality of life. So again here we can see that this was again study from India. Again it was showed that the patients who were on IDAC-ASP, they had better glycemic controlled, and they preferred, and that the quality of life was better with IDAC-ASP also. And there was a reduction in pill burden because with the usage of IDAC-ASP, the requirement of glimepiride was decreased.
Who have taken the much interest in streamlining the meeting. So today it was the first meeting, it has a good response. So once again I am thankful to all. I am also inviting the non-disc member, please give a, I am also thankful to them for arranging a beautiful meeting.
So first of all, thank you very much to our respected speakers who has given a fantastic talk today. And we are privileged, as a Novo Nordisk, we are privileged to be the part of this is the first meeting of the Physician Forum. So thank you very much. You have given us the opportunity to be part of this meeting. Sir, I would like to share with you about Novo Nordisk. Novo Nordisk has completed 100 years on 16th of February 2023. So we are really thankful to our respected doctors who has supported us in this 100 years of journey. And we as an organization are committed complete for India. I know you must be thinking that there are n number of organizations who are winding up their operations from India, but no one is completely complete for India. At least I can tell you as a regional manager of Novo Nordisk, we are having at least 30-40 years of the brand which we are planning to launch in India. The first brand which we are going to launch in India is Icodex, which is 120 vessel system, maybe within a year or maybe within a 15 months. We have already applied the approval. After that, we are going to plan to launch SEMA 2.4 milligram, which is the VOP, this is the anti-obesity. After that, we are going to launch IcoSema. After that, we are going to launch a fantastic anti-obesity.
क्या बात है आज की चांदनी कि हम खो गए प्यार की रागिनी ये बाहों में बाहें ये बहकी निगाहें लो आने लगा जिंदगी का मजा ये रात ये मौसम नदी का किनारा ये चंचल हवा कहा दो दिलों ने मिलकर अब हम न होंगे जुदा ये रात ये मौसम नदी का किनारा ये चंचल हवा ये क्या बात है आज की चांदनी में कि हम खो गए प्यार की रागिनी में ये बाहों में बाहें ये बहकी निगाहें लो आने लगा जिंदगी का मजा ये रात ये मौसम नदी का चंचल रहे साथ जब तक ये बंधन न टूटे तुम्हें दिल दिया है ये सौदा किया है सनम अब तुम्हारी रहूंगी सदा ये रात ये मौसम
ओ महबूबा तेरे दिल के पास ही है मेरी मंजिल मकसूद तेरे दिल के पास ही है मेरी मंजिल मकसूद तेरे दिल के पास ही है मेरी मंजिल किस बात पे नाराज हो किस बात का है गम किस सोच में डूबी हो तुम हो जाएगा संगम ओ महबूबा तेरे दिल के पास ही है मेरी मंजिल तेरे दिल के पास ही है मेरी मंजिल
हाँ जी ਸੈਮੀਨਾਰ ਜਿਹੜਾ ਸਾਡਾ ਅੱਜ ਫਿਜ਼ੀਸ਼ੀਅਨ ਫੋਰਮ ਦਾ ਸੀ ਮਾਈਸੈਲਫ ਡਾਕਟਰ ਬੈਂਸ ਸਿੰਘ ਮਾਨ ਆਈ ਐਮ ਸੈਕਟਰੀ ਆਫ ਫਿਜ਼ੀਸ਼ੀਅਨ ਫੋਰਮ ਬਠਿੰਡਾ ਅੱਜ ਜਿਹੜੀ ਸਾਡੀ ਮੀਟਿੰਗ ਹੋਈ ਹੈ ਇਹਦੇ ਬਾਰੇ ਮੈਂ ਇੰਨਾ ਕਹਿਣਾ ਚਾਹਾਂਗਾ ਕਿ ਇਹਦੇ 'ਚ ਅਸੀਂ ਮਰੀਜ਼ਾਂ ਦੇ ਜਿਹੜੇ ਸ਼ੂਗਰ ਦੇ ਪੇਸ਼ੈਂਟਸ ਹੁੰਦੇ ਆ ਉਹਨਾਂ ਦੀਆਂ ਸਮੱਸਿਆਵਾਂ ਬਾਰੇ ਅਸੀਂ ਡਿਸਕਸ਼ਨ ਕੀਤੀ ਹੈ ਜ਼ਿਆਦਾਤਰ ਕਿ ਉਹਨਾਂ ਦੀ ਸ਼ੂਗਰ ਲੈਵਲ ਕਿਸ ਤਰ੍ਹਾਂ ਕੰਟਰੋਲ ਕਰ ਸਕਦੇ ਆਪਾਂ, ਕਿਉਂਕਿ ਜਿਹੜੇ ਹਸਪਤਾਲਾਂ ਦੇ ਵਿੱਚ ਦਾਖਲ ਮਰੀਜ਼ ਹੁੰਦੇ ਆ ਉਹਨਾਂ ਦੀ ਸ਼ੂਗਰ ਲੈਵਲ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹਾਈ ਹੁੰਦੇ ਨੇ ਅਤੇ ਉਹਨਾਂ ਨੂੰ ਜ਼ਿਆਦਾਤਰ ਆਪਾਂ ਇਨਸੂਲਿਨ ਵਗੈਰਾ ਦੇ ਕੇ ਹੀ ਉਹਨਾਂ ਦੀ ਸ਼ੂਗਰ ਕੰਟਰੋਲ ਕਰ ਸਕਦੇ ਹਾਂ। ਪਰ ਜੇ ਉਹਨਾਂ ਦੀ ਸ਼ੂਗਰ ਕੰਟਰੋਲ ਨਹੀਂ ਕਰਦੇ ਤਾਂ ਉਹਨਾਂ ਨੂੰ ਵੱਖ-ਵੱਖ ਤਰ੍ਹਾਂ ਦੀਆਂ ਸਮੱਸਿਆਵਾਂ ਦਾ ਸਾਹਮਣਾ ਕਰਨਾ ਪੈਂਦਾ ਹੈ, ਜਿਵੇਂ ਕਿ ਉਹਨਾਂ ਦੇ ਗੁਰਦੇ ਖਰਾਬ ਹੋ ਜਾਂਦੇ ਹੈ, ਉਹਨਾਂ ਦੇ ਹਾਰਟ ਅਟੈਕ ਦੀ ਪ੍ਰੋਬਲਮ ਆਉਂਦੀ ਹੈ, ਉਹਨਾਂ ਨੂੰ ਅਧਰੰਗ ਦੀ ਪ੍ਰੋਬਲਮ ਆਉਂਦੀ ਹੈ। ਸੋ ਇਹਨਾਂ ਦੇ ਜਿਹੜੇ ਦਾਖਲ ਮਰੀਜ਼ ਹੁੰਦੇ ਆ ਉਹਨਾਂ ਦੀ ਆਪਾਂ ਸ਼ੂਗਰ ਲੈਵਲ ਆ ਜਿਹੜੀ ਇਨਸੂਲਿਨ ਇੰਜੈਕਸ਼ਨ ਦੇ ਕੇ ਹੀ ਕੰਟਰੋਲ ਕਰ ਸਕਦੇ ਹਾਂ, ਅਤੇ ਜੇ ਇਨਸੂਲਿਨ ਨਹੀਂ ਦਿੰਦੇ ਤਾਂ ਉਹਨਾਂ ਦੀ ਸ਼ੂਗਰ ਲੈਵਲ ਕੰਟਰੋਲ ਨਹੀਂ ਹੋਏਗੀ, ਉਹਨਾਂ ਨੂੰ ਵੱਖ-ਵੱਖ ਦਿੱਕਤਾਂ ਦਾ ਸਾਹਮਣਾ ਕਰਨਾ ਪਊਗਾ। ਇਹ ਸਾਡੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਜਿਹੜੇ ਅੱਜ ਡਿਸਕਸ਼ਨ ਦੇ ਵਿੱਚ ਆਏ, ਡਾਕਟਰ ਸੁਸ਼ੀਲ ਕੋਟਰੂ ਸੀਗੇ ਐਂਡ ਡਾਕਟਰ ਸਵੇਤਾ ਵਾਂਸਲ ਸੀਗੇ, ਵਨਡੇ ਕਰਨੋਲੋਜਿਸਟ ਸੀਗੇ। ਉਹਨਾਂ ਦੇ ਵਿੱਚ ਉਹਨਾਂ ਨੇ ਇਹੀ ਡਿਸਕਸ਼ਨ ਕੀਤੀ ਵੀ ਕਿਸ ਤਰ੍ਹਾਂ ਦੇ ਇਨਸੂਲਿਨ ਅਸੀਂ ਵਰਤ ਸਕਦੇ ਹਾਂ। ਵੱਖ-ਵੱਖ ਤਰ੍ਹਾਂ ਦੇ ਇਨਸੂਲਿਨ ਹੁੰਦੇ ਆ ਸ਼ੂਗਰ ਦੇ ਪੇਸ਼ੈਂਟਸ ਦੇ ਵਿੱਚ। ਇਹ ਸ਼ੂਗਰ ਦੇ ਜਿਹੜੇ ਮਰੀਜ਼ ਹੁੰਦੇ ਆ ਜਾਂ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਦੇ ਮਰੀਜ਼ ਹੁੰਦੇ ਆ, ਇਹਨਾਂ ਨੂੰ ਸਭ ਤੋਂ ਜ਼ਰੂਰੀ ਜਿਹੜੀ ਹੈਗਾ ਆਪਾਂ ਨੂੰ ਜਿਹੜੀ ਸਿੱਖਿਆ ਦੇਣੀ ਪੈਂਦੀ ਹੈ ਉਹ ਇਹ ਹੈ ਕਿ ਉਹਨਾਂ ਨੂੰ ਆਪਣਾ ਬਲੱਡ ਸ਼ੂਗਰ ਲੈਵਲ ਅਤੇ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਉਹ ਕੰਟਰੋਲ ਕਰਕੇ ਰੱਖਣਾ ਪੈਂਦਾ, ਕਿਉਂਕਿ ਠੀਕ ਹੋਣ ਵਾਲੀਆਂ ਬਿਮਾਰੀਆਂ ਨਹੀਂ ਹੁੰਦੀਆਂ, ਇਹ ਸਿਰਫ ਕੰਟਰੋਲ ਹੋਣ ਵਾਲੀਆਂ ਬਿਮਾਰੀਆਂ ਹੁੰਦੀਆਂ। ਜੇ ਉਹ ਕੰਟਰੋਲ ਰੱਖਣਗੇ ਤਾਂ ਉਹਨਾਂ ਦੀ ਜ਼ਿੰਦਗੀ ਲੰਬੀ ਹੋਊਗੀ, ਜੇ ਕੰਟਰੋਲ ਨਹੀਂ ਰੱਖਣਗੇ ਤਾਂ ਉਹਨਾਂ ਦੀ ਜ਼ਿੰਦਗੀ ਘੱਟ ਜਾਊਗੀ ਅਤੇ ਉਹਨਾਂ ਦੀ ਜਿਹੜੀ ਕੁਆਲਿਟੀ ਆਫ ਲਾਈਫ ਹੈ ਉਹ ਵੀ ਪੂਰ ਹੋ ਜੂਗੀ। ਕਿਉਂਕਿ ਉਹਨਾਂ ਨੂੰ ਵੱਖ-ਵੱਖ ਤਰ੍ਹਾਂ ਦੀ ਕੰਪਲੀਕੇਸ਼ਨਾਂ ਦੇ ਵਿੱਚ ਨਿਕਲਣਾ ਪੈਂਦਾ ਹੈ, ਜਿਵੇਂ ਕਿ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਸ਼ੂਗਰ ਦੇ ਮਰੀਜ਼ਾਂ ਨੂੰ ਹਾਰਟ ਅਟੈਕ ਆ ਜਾਂਦਾ ਹੈ, ਅਧਰੰਗ ਹੋ ਜਾਂਦਾ ਹੈ, ਜਿਹਨੂੰ ਕਿ ਅਸੀਂ CBA ਕਹਿੰਦੇ ਡਾਕਟਰੀ ਭਾਸ਼ਾ ਦੇ ਵਿੱਚ। ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਗੁਰਦੇ ਖਰਾਬ ਹੋ ਜਾਂਦੇ ਆ ਅਤੇ ਉਹਨਾਂ ਨੂੰ ਫਿਰ ਵੱਖ-ਵੱਖ ਤਰ੍ਹਾਂ ਦੀਆਂ ਮੁਸ਼ਕਿਲਾਂ ਦਾ ਸਾਹਮਣਾ ਕਰਨਾ ਪੈਂਦਾ ਹੈ ਅਤੇ ਉਹਨਾਂ ਦੀ ਜ਼ਿੰਦਗੀ ਕਾਫੀ ਲੰਬੀ ਹੋਣ ਦੀ ਜਗ੍ਹਾ ਘੱਟ ਜਾਂਦੀ ਹੈ। ਇਸ ਕਰਕੇ ਸਾਨੂੰ ਸਾਰਾ ਜਿਹੜਾ ਮਤਲਬ ਹੈ, ਜਿਹੜਾ ਮੰਤਵ ਹੈ ਬੇਸਿਕਲੀ ਫਿਜ਼ੀਸ਼ੀਅਨ ਫੋਰਮ ਦਾ, ਇਹਦੇ 'ਚ ਅਸੀਂ ਲੋਕਾਂ ਨੂੰ ਪ੍ਰੋਪਰਲੀ ਗਾਈਡ ਕਰਨਾ ਹੈ। ਕੀ ਗਾਈਡ ਕਰਨਾ ਹੈ ਵੀ ਉਹ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਅਤੇ ਸ਼ੂਗਰ ਕਿਸ ਤਰ੍ਹਾਂ ਆਪਣਾ ਕੰਟਰੋਲ ਕਰ ਸਕਦੇ, ਪ੍ਰੋਪਰਲੀ ਫੋਲੋ ਅਪ ਕਰਨਾ ਉਹ ਡਾਕਟਰ ਕੋਲੇ। ਇਸ ਤਰ੍ਹਾਂ ਨਹੀਂ ਹੈਗਾ ਵੀ ਇੱਕ ਵਾਰੀ ਦਵਾਈ ਲੈ ਲਈ ਅਤੇ ਠੀਕ ਹੋ ਗਏ ਅਤੇ ਮੁੜ ਕੇ ਦਵਾਈ ਦੀ ਲੋੜ ਨਹੀਂ ਹੈਗੀ, ਕਿਉਂਕਿ ਮੈਂ ਵਾਰ-ਵਾਰ ਕਹਿੰਦਾ ਇਹ ਕਰੋਨਿਕ ਡਿਜ਼ੀਜ਼ ਹੈ, ਲਾਈਫ ਸਟਾਈਲ ਡਿਜ਼ੀਜ਼ ਹੈ ਬੇਸਿਕਲੀ। ਇਹ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਸ਼ੂਗਰ ਹੈ ਜਿਹੜੀ, ਜੇ ਆਪਾਂ ਨੂੰ ਕੰਟਰੋਲ 'ਚ ਰੱਖਾਂਗੇ ਤਾਂ ਆਪਣੇ ਇੰਟਰਨਲ ਔਰਗਨ ਸਹੀ ਰਹਿਣਗੇ। ਇੰਟਰਨਲ ਔਰਗਨ ਮਤਲਬ ਗੁਰਦੇ, ਹਾਰਟ, ਕਿਡਨੀ, ਬ੍ਰੇਨ, ਨਰਵਜ਼ ਵਗੈਰਾ ਹਨ, ਉਹ ਸਾਰੇ ਸਹੀ ਰਹਿਣਗੇ। ਜੇ ਨਹੀਂ ਕੰਟਰੋਲ ਰੱਖਾਂਗੇ ਤਾਂ ਉਹ ਸਾਰਿਆਂ ਦਾ ਨੁਕਸਾਨ ਹੋ ਹੀ ਜਾਊਗਾ ਅਤੇ ਬੰਦੇ ਦੀ ਜ਼ਿੰਦਗੀ ਜੇ 70 ਸਾਲ ਤੱਕ ਉਹਨੇ ਜਿਉਣਾ ਤਾਂ 50 ਤੇ ਵੀ ਮਸਾਂ ਪਹੁੰਚੂਗਾ ਅਤੇ ਉਹ ਵੱਖ-ਵੱਖ ਤਰ੍ਹਾਂ ਦੀਆਂ ਕੰਪਲੀਕੇਸ਼ਨਾਂ ਦੇ ਵਿੱਚ ਘਿਰ ਜਾਊਗਾ। ਉਹਦੇ ਪੈਸੇ ਵੀ ਵੱਧ ਲੱਗਣਗੇ, ਉਹਨੂੰ ਵਾਰ-ਵਾਰ ਹਸਪੀਟਲਾਈਜੇਸ਼ਨ ਉਹ ਕਰਨੀ ਪਊਗੀ, ਵਾਰ-ਵਾਰ ਹਸਪਤਾਲ 'ਚ ਦਾਖਲ ਹੋਣਾ ਪਊਗਾ ਅਤੇ ਜਿਹੜਾ ਇਲਾਜ ਆ ਉਹ ਹਸਪਤਾਲ ਦਾ ਕਾਫੀ ਮਹਿੰਗਾ ਹੈ ਨਾ। ਇਸ ਤਰ੍ਹਾਂ ਇਹ ਬੇਸਿਕਲੀ ਸਾਡਾ ਮੁੱਦਾ ਇਹੀ ਸੀਗਾ ਕਿ ਲੋਕਾਂ ਨੂੰ ਕਿਸ ਤਰ੍ਹਾਂ ਐਜੂਕੇਟ ਕੀਤਾ ਜਾਵੇ, ਸਮਝਾਇਆ ਜਾਵੇ ਕਿ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਅਤੇ ਸ਼ੂਗਰ ਦੀ ਬਿਮਾਰੀ ਹੈ ਜਿਹੜੀ ਐਕਸਰਸਾਈਜ਼ ਨਾਲ, ਡਾਈਟ ਕੰਟਰੋਲ ਕਰਕੇ ਅਤੇ ਦਵਾਈ ਲੈ ਕੇ ਹੀ ਕੰਟਰੋਲ ਹੋ ਸਕਦੀ ਹੈ। ਤਾਂ ਹੀ ਆਪਾਂ ਇਹਨਾਂ ਦੀਆਂ ਜਿਹੜੀ ਕੰਪਲੀਕੇਸ਼ਨ ਹੁੰਦੀਆਂ ਉਹਨਾਂ ਤੋਂ ਬਚ ਸਕਦੇ ਅਤੇ ਲੰਬੀ ਜ਼ਿੰਦਗੀ ਜਿਉ ਸਕਦੇ। ਥੈਂਕ ਯੂ ਸੋ ਮਚ।